Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
I'm James Larkin. Hi.
Hi. Why don't we talk injectable therapy today? Intratumoral, intralesional, injectable, however we're kind of describing this. And that will get us to maybe the only approval we have in this space at the moment, Talimogene Laherparepvec. Before we do, maybe a rapid fire question or two, James. Who is the most famous person you've ever met?
I don't know if I can say, probably, for confidentiality reasons.
I'm sure you made the news.
That's true, actually. Yeah. No, that's probably right. Yeah, so I've met Prince William now a few times, actually. He's the patron of our institution. So, yeah, that's stuff's in the public domain. I don't know how you measure fame exactly, though, but I suspect that's the answer. I don't think I've secretly met anyone more famous. Like,
Prime Minister or
Taylor Swift. I was thinking.
Don't tease me. Don't do that to me. All right.
Yeah, you asked for that.
Yeah. It's a setup. Maybe related. There's fame, and then there's people we kind of adore, admire, mentor. Is there somebody in your life that's been just a really impressive mentor, or somebody that you admire that's been in your life?
Yeah, I mean, again, some of that I can't say actually in the public domain, so that's one thing. But the person that's professionally mentored me most is my colleague Martin Gore, who died just over 5 years ago suddenly, who basically we first met when I was a very junior doctor resident, I think, in your terminology. And actually he was the reason that I did oncology in the first place. And I ended up working with him for 15, 20 years. From me being very, very junior doctor to joining the faculty, and then we worked together for 10 years on faculty. So yeah, Martin taught me a lot, and it calmed me down a lot as well, actually. So thank you, Martin, if you're listening.
Excellent. Well, okay, let's talk about the OPTiM trial. The OPTiM trial has been published in a couple of places, I think originally in JCO in 2015. I should probably know, was that Robert Mbaka who was the principal on that one?
Yeah.
It's like it.
Yeah.
And then you and I were coming across this final analysis that was published, final analysis of OPTiM, randomized phase 3 trial of Talimogene Laherparepvec versus GM-CSF, essentially granulocyte macrophage colony stimulating factor in unresectable stage 3-4 melanoma. This is also Robert Mbaka, first author, Howard Kaufman, senior author in the Journal for Immunotherapy of Cancer, the home journal of SITC, and this was 2019 published. So, James, and maybe people are familiar with the study design, but maybe if for people who aren't, is it worth a discussion of just the design, the control arm, and the patient population here?
Yeah, absolutely. So a couple of things first. One is that your pronunciation is very impressive. I'm not even going to attempt to pronounce the whole thing. I'll just say T-VEC because that's loads easier. And then I think the second background comment is that oncolytic viruses, I mean, it's quite cool in my opinion. It's been going for a long time, and there's lots of different oncolytic therapies that have been trialed for cancer. But I guess the important thing here with T-VEC is the approval. And I suspect actually we're going to see more approvals in the coming years. So that for me is the background. And this is a modified herpes virus. And I guess if we talk about the OPTiM trial, it's a randomized trial of T-VEC, which is an injectable. So you need injectable lesions, which are usually going to be sort of subcutaneous disease, lymph nodes, that kind of thing. So there's an issue there about what's injectable and what isn't from a technical perspective. That's maybe the first thing to say. And then the other thing about the trial, or one of the other things about the trial, was the control arm, which was GM-CSF. I mean, we wouldn't have considered that a sort of standard of care at the time. And that's probably a discussion point. This trial recruited pretty much before we had general availability of effective systemic treatment. So I think that's one thing to say. Had there been a placebo control arm, would that have played? Would it have recruited? I'm not really sure about that. So what do I think about GM-CSF as a control arm? I think it's okay. And actually it transpires, it looks like there was a bit of activity there as well. So I wouldn't say that was a major limitation of the trial. I think the one thing, though, in terms of trial design, and actually we contributed to this at our institution, it's a group of patients which is quite significantly selected, I think, from your population of patients who've got advanced melanoma. So injectable disease, we've said already, is one thing. But if you look at the inclusion criteria for the trial, there are, I think, a few other relevant things. One of them, and I remember this, was LDH either equal or less than 1.5 times the upper limit of normal. And a lot of patients, certainly in our clinic, have an LDH that's higher than that. They did then, and they still do now today in 2024. And then there were restrictions. Go on.
Sorry to interrupt, but you think that's true even with this on the spectrum of disease? We're talking about kind of the left-hand side of the spectrum, injectable, nodal, subcutaneous, cutaneous disease. You think it's true that even a fair portion of those are exceeding 1.5 times upper limit? I tend to associate LDH with visceral things, but
I suppose, yeah, well, that's maybe the point I'm making, that you'll have some people who've got something that's technically injectable, but then they'll also have some liver mets or something like that, blah, blah, blah. And so they'll have a high LDH. So it's yeah, I mean, so the point I'm making is you might have someone who's got something injectable, they're going to have a load of other stuff as well, including a high LDH, or actually, whether it's a high LDH or not, you could even discuss that, because it's 1.5 the cutoff here, it's not 2. And if people are doing cutoffs, I think if you're picking a cutoff, you'd probably say 2, but let's just park that for a second. And then the other thing to comment on, I think, is that you need to have either 3 or no more than 3 visceral lesions, excluding lung or nodal lesions. I'm reading from the protocol, associated with visceral organs, and none greater than 3 centimeters in size, so that's just over an inch. So then if you put all of those things together, imagine a Venn diagram for patients in the clinic: injectable, low LDH, small volume disease, etc. I remember when we were recruiting into this study with Kevin Harrington, who I work with at my institution, who's one of the investigators on the study, it wasn't that easy to find patients for the study, actually, so they're pretty highly selected. Anyway, so I think that's important to bear in mind. And then if we look at the readout of the trial, which you just cited, there's a few maybe different things. It's about 430 patients, 2-to-1 randomization, so 300 T-VEC and 140 odd GM-CSF, about 4 years of median follow-up, and then the median OS just about 2 years in the T-VEC arm, and then 19 months, a bit less, in the GM-CSF arm. So hazard ratio there, 0.79, and the confidence interval was 0.62 to 1.0, so just coming in under 0.05 p-value, but that's descriptive. I think if you look at a few of the other things there, you're seeing improved response, so that's around about 30% versus 6%. And then in the publication, they talk a little bit about how well the patients with CR do. I'm never a massive fan of saying how well the patients with CR do, because I think we know that if you have a CR, maybe it doesn't even matter what the treatment is, you're probably going to do quite well. So I would just I wouldn't read too much into that. But I mean, I suppose my bottom line here is that this is a treatment that has activity, and you can make these comments about the control arm and highly selected patients, but the treatment does have activity and it has regulatory approval. Sorry, you're going to say?
Yeah, I have a few things to say. First, I noticed that nod to the imperial system when you said just over an inch for 3 centimeters. I like that. Thank you for that conversion past math. Also, I think this idea of presenting patients that achieve a CR as some, novelty, if you get a CR to anything, you tend to be, an excellent responder. It's not that CRs are necessarily brief in duration. That speaks often to a deeper biology that we haven't necessarily fully uncovered. But, a caveat is when I see these Kaplan-Meier curves that are graphed by CR versus PR versus stable disease. And of course, you guys did this with Checkmate 067 in a presentation. I don't think I ever saw it in print. It's fine to present it that way. I think it tells us that obviously having a CR gives you this tail on the curve at this point and this survival that exceeds a PR that exceeds, but it's not exactly statistically sound to graph it that way because you're graphing a post randomization event at the time, as if it's occurring from randomization. So it's a little bit, I mean, this is sort of a grotesque analogy. I haven't replaced it in my head with another one, but it's sort of like saying survivors of a bus crash live better than those who succumb to the bus crash. Of course, because you survived it, because you had that excellent, out. It wasn't like you both got on the bus at the same time and you couldn't have told who was going to be a survivor and a survivor at that point. But after the fact, you can tell and you can say, oh, the people who survived did better. So the people with a CR after you started treatment, of course, do better. The question is, do you know who they are at randomization? Of course not. But I guess that's to say that. And one other comment on this control arm, subcutaneous GM-CSF, it was not a standard therapy anywhere really, and a bit of a controversial um, uh, mechanism of action, if you will, unless maybe, we didn't really talk about T-VEC and what it's comprised of. It's comprised of an attenuated herpes virus that also has GM-CSF encoded to it. And I recently called it herpes light at a patient symposium. And then I got ribbed for that by every speaker after that. It was like, oh, herpes light sounds great. My point was that it's typically a non-infectious herpes, though it can lead to some reactivation in rare instances. So the GM-CSF is fairly controversial because I think in some camps in melanoma, this was considered pro-tumorigenic. Tumors had GM-CSF receptors, and so that you could see GM-CSF maybe spurring on melanoma. And then there was the other faction that said, no, GM-CSF recruits your monocytes. It is recruitment of an immune system that can be anti-tumorigenic. And I don't know if we've ever really split the difference. Lynn Spidler is one of the famous sort of queens of GM-CSF in California. And from what I understand from my former mentor, Kevin Kim, she still goes around and does these Spidler rounds at age 90 and, once a month or so, and people come and congregate and watch her do rounds. But she was one of the believers that GM-CSF could be therapeutic. But, all to say that GM-CSF really didn't have a therapeutic place necessarily in our arsenal. And the control arm was not intratumoral. The control arm was subcutaneous, as we would use it as a regular growth factor. And so you also had these different modalities. And I say that because as we interpret things now, in terms of durable response rate and injected tumor response rates, we have to remember that the control arm here was not injected into the tumors. So it was more of a distant therapy. So just a couple.
Yeah. So I mean, for me, the real question about this is how you would use it in clinic. And I guess we talked a little bit about this already. We have it reimbursed. We'll come on to talk about some of the combination studies in due course because that's interesting, I think. But as a single agent, as per the label, what sort of situations do you use it in? And I already know that you inject it yourself, which is extremely impressive. So maybe you can chat through some of the practical issues in clinic.
So now you've just gotten to a bigger issue, which is that you wear scrubs to work and you don't inject the TVEC. And I run around in blouses and high heels and I do the TVEC. What does that say?
Yeah, what does that say about me? So do you put scrubs on to inject the T-VEC, or do you do it in this outfit that you're wearing now?
I do it in an outfit and I put on a gown and I put on sterile gloves and a splash guard, but I don't. At my previous institution, I didn't have access to scrubs. They were restricted to surgeons and interventional radiologists and certain proceduralists. So I had gone down to the vending machine and swiped my badge, and the "No, you are not authorized" was massive. So that's that. But I know you had a similar issue where you're maybe we shouldn't say it on the podcast, but you're actually sneaking scrubs out of the laundry area.
Well, yeah, I don't know if we should discuss that in public or not, but yeah.
Operational
So,
issue. So,
yeah, it's an operational issue. Yeah, go on.
yeah, the TVEC is to be injected. There's a dosing table. So you measure your tumor that you're injecting, and then you get a certain volume of TVEC to inject in that tumor. And you just, the table's pretty simple to go through. And you inject no more than 4 milliliters maximum. Let me go back to the operational issue. You use this dosing table for TVEC, you measure your tumor, and then you inject. So tumors less than 0.5 centimeters, which you can get as a 4 or 5 millimeter in transit disease. So less than or equal to 0.5, you're injecting 0.1 milliliters. And I would challenge anybody to go to their clinic and put a needle on a syringe, on your smallest tuberculin syringe. Find the shortest needle that you can, which many times is not that short. Back to imperial system, it's going to be a half inch or an inch needle, and then try to get 0.1 mLs of water or saline out of that needle hub. That's pretty difficult. It's getting likely trapped in that needle as you depress the plunger. So 0.1 is the smallest injection volume. The next injection volume is 0.5 mLs. And then it goes up to 4 mLs if you have a greater than 5 centimeter, 2-inch tumor. The truth is, I have a couple of things to say about injecting these. First of all, I think it matters the ratio of TVEC you're getting to tumor. So for people who inject, they probably have some instinct about this as well. When you can saturate a tumor nicely, probably 50% or more with TVEC, and that goes to the size and volume issue, that's where you're likely over time to see benefit and you're going to see a clinical response. If you take a 2-inch tumor, so my knuckle is an inch or so, here's 2 inches. So here's a 5 centimeter tumor. I mean, I have proper calipers I could use here, but, and you inject 4 mLs. 4 mLs is actually not that much, volume in this rounded tumor that is, a good ping pong ball larger size. You're not saturating much of that tumor with the TVEC. And so the chance that that's going to turn into a complete response, I think, are lower. So I guess my take home message is really it is worth picking those tumors that are smaller, injecting those. The larger tumors, maybe another approach or need systemic therapy. I don't inject anything where I think there could be a blood vessel coursing over it. So ultrasound for lymph nodes. We don't have access to an ultrasound machine in clinic as medical oncologists, so I leave that for the surgeon or interventional. A subcutaneous nodule, say in the abdomen, chest wall, torso, maybe superficial in the groin, and then obviously on top of the skin. I think these are all reasonable to inject, but the size matters. Maybe that's a take home for this. Size matters when injecting with TVEC. The other thing is if I have some of those small tumors, less than 0.5 centimeters, 5 millimeters or less, that are asking for 0.1 on the TVEC dosing schedule, I exaggerate. I call those 6 millimeters, 7 millimeters, so I can go up a dosing level to 0.5 mLs. And now I can know I can comfortably get that out the needle hub into the tumor. Am I injecting the whole 0.5? Maybe not, but because I'm aware of the saturation issue, I'm trying to saturate that tumor. So that's sort of the bottom line. This is attenuated herpes, so you do have to do viral deep cleaning of your clinic room or your procedure room afterwards. which can put it out of commission for, 30 minutes or an hour, however long it takes to deep clean. You do have to dress it and then with an occlusive dressing, and then swab that dressing with an alcohol swab. And theoretically, you should tell the patients, let that dressing fall off after 7 days, but keep away from people who have not been exposed to a herpes virus. So, fetuses, infants, obviously pregnant women who are carrying the fetus, just keep away from them so as not to maybe cause issues there, though the reports and rates of that would be very low. And then just beware that there can be very, very rare instances of herpes simplex reactivation that patients can have. And it's probably more of just an immune response to, what the immune system is doing to the T-VEC. It's not T-VEC causing it so much. It's more of an indirect effect that can happen, but something we have to watch for.
Yeah, well, that's all very helpful, interesting information. Actually, our surgeons are the ones that inject here, despite the fact that I'm wearing scrubs. But I guess different places will have different setups. What I kind of also want to ask is that what does a T-VEC patient look like? Is this all people who've never had systemic treatment before, and then they've got this pattern of disease, if you want to call it that, that's suitable for T-VEC? Or is this someone who's actually quite heavily pre-treated with other systemic treatments, but they still fit the bill for T-VEC, and it's a kind of a later line of treatment, or is it a bit of both?
I think it's the former that you described, and that speaks to, as you were talking about eligibility for this OPTiM trial, this was sort of naturally going to get somebody a little earlier in their disease course, low visceral disease, if they had visceral, small volume, physical volume of it. But really, I think the melanoma field has shifted to, they don't even want the patients with the visceral disease, right? They really want those patients who are visceral free, which, as you and I have talked about, what percentage of our clinic population is that anyway? It's a low percentage. 10% or less are going to be visceral disease free. And then you are catching them just by incubation theory. You're catching those patients earlier in their disease course. If you get somebody who's had heavy, and by the way, let me wrap up that point. They could be older. They might not be able to tolerate systemic therapy, because we know systemic checkpoint inhibitor can also work in this in transit and M1A sort of situation, 3C situation. But maybe you want to spare them the systemic side effects. Maybe they're carrying a bit of mild autoimmunity and you just want to try something injectable first. As you alluded to, maybe this lends us to really dive deep into injectable plus systemic therapy for this population, and how to best utilize it, and maybe how were some of the trials done that may have missed the mark a little bit on optimizing this. Maybe that's the first point. They don't have to be older, but yeah, that might be a consideration. The second group of patients that might be heavily pretreated but might end up eligible here, injectable disease. If we're being honest, we should remember that LDH that you pointed out. So what about that LDH being controlled, which sometimes you don't see in the heavier pretreated patients? Then you see the LDH kind of ramping up and up. But this goes to the theme that you've had across these podcasts about tempo. If you get somebody and you control their disease, and with multiple lines of therapy, and they have a brief melanoma-free period, brief or meaningful, melanoma-free period, and then show up in some form or fashion with injectable disease, this might be something to consider if you feel the tempo is moderate enough that this could work. But then by that same tempo that's moderate, maybe single agent checkpoint inhibitor might be beneficial for that population. But by and large, I think the patients I pick out for this are those earlier, that first case.
Yeah, no, I think those are all nice points. And there are actually patients in the real world who you might want to treat with a checkpoint inhibitor, but for whatever reason, there's risks attached to it autoimmune. And we have a few of those patients, and we actually think, maybe the benefit risk for T-VEC is better than a checkpoint inhibitor. I think that's a real thing.
Mm-hmm.
The other group that we seem to be, using T-VEC quite a lot on is the recurrent acral melanomas. I don't know if you and I have discussed this before, but you've got someone who might have a sort of nasty, thick primary, usually in their foot. So they'll have had that resected. They may have had adjuvant treatment. They may not have done with anti-PD-1 or occasionally BRAF-targeted therapy. And then if they recur, they will often recur in the leg and quite often not have other visceral disease. So then, generally they will have had some systemic treatment. And we definitely think about T-VEC there, but again, it sort of comes a little bit back to the pattern of disease. And, even in the leg, shall we say, there's a really broad church of clinical presentations. You have some people with really big lumps and you think, no. Then, have the miliary patterns and kind of everything in between. And then you have and actually, joking aside, this might have been one of the reasons that we thought it was good to get our surgeons to do this, because this group of patients in particular, some of them probably should have surgery, and then there's an issue about what surgery and when.
Yeah.
And then so we do isolated lymphofusion still. Actually, that might be interesting to talk about that. I don't know if that's something that you do. And I think we thought we might stop doing ILPs when we had checkpoint inhibitors, but we haven't. We're still doing ILPs, usually in refractory, and it can work quite well. But yeah, go on.
Yeah. You bring up so many good points there that I guess I hadn't connected the dots in my head, but now I'm connecting them. These acral patients do tend to have a very injectable sort of recurrence pattern. Maybe it's not even their first recurrence, because they might go nodal first and then you do something and then. So you're making me think of, and so they were probably a setup for this type of injectable therapy. And have we really looked at the efficacy of these types of treatments for them? But as you and I have talked about, it's going to be impossible to do a dedicated acral trial. Isolated lymphofusion is how we used to treat these patients. We have not done one in years, would be my estimation, but I'm speaking a bit out of turn since I'm not a surgeon. But speaking of our surgical colleagues, one of our dear colleagues that you and I know well, Merrick Ross, he and I shared a patient this last year that was utterly gratifying. It was scary for a brief moment, and it ended up being quite gratifying. An acral melanoma on the toe. It was on the probably big toe, second toe region, removed. And then in short course, sentinel lymph nodes were negative, but in short course, there became some sentinel nodes. And so, or some palpable nodes in the groin. And so we applied the SWOG S1801 approach and exposed this patient to 3 doses of pembrolizumab. And there wasn't much pathologic response. But, pathologic response, while it's important, doesn't have to run the day. We still got the tumor out. The guy was still able to go to surgery, and he resumed pembrolizumab in the post-operative setting. And after several months, maybe 3 months, maybe 6 months, there were recurrences at the guillotine site of his toe. So at that tumor bed site, there were a couple of black spots there that were biopsy proven. And then in the groin, in more of a superficial, unclear that it was a lymph node, but a superficial nodule had developed. So now this patient had been exposed to pembrolizumab. The question was, do we go all the way to ipi-nivo? We could resect, we could inject. So we chose to do ipilimumab plus T-VEC. And so Merrick was injecting the toe bed and the groin, and I was administering ipilimumab. And there was a moment where we were trying to decide and when we did it almost to just kind of assess this tempo question. Did we need to go all the way to ipi-nivo? There were a lot of other considerations for this patient who was international and, was coming from out of state and all these other things. And then Merrick ended up going to surgery just to resect some, what little bit, in that tumor bed area. It faded pretty quickly, let's say after 3 or 4 months, and then he resected. And it was so gratifying. It's the one time in my 16 years in Houston that he called me on a Saturday to say, did you see the path report on this guy? This looks fantastic. And it really spoke to, I think, maybe it was the acral. Did the previous checkpoint set him up for, immune priming so that the injection could work better? Who knows? It was also just having some sort of instinct about this patient has a little bit of disease and we might not have exhausted all the things we can do, and here we are now many, many months later, and he's remained no evidence of disease, finished the IPI courses. We got the toxicity from IPI. We may not have even done all 4 doses because of some toxicity. And here we are. So you made me connect the dots that there might be a very nice acral patient with that pattern of recurrence, whether it's their first occurrence or even after exposure, where this may really be reasonable. And whether the IPI was necessary, I think remains in question, but it's nice that, it's nice that we have the option in the US, I think, to combine these things.
Yeah, I mean, just quickly on that, because we probably need to wrap up. But I mean, I see these patients with the surgeons every time, and we know that we've got the Ipi-Nivo sort of at the end of the line if we need it. And
Right.
it's very much a conversation. Actually, if you don't have much volume of disease, it feels like it's quite heavy going to go in with Ipi-Nivo at the start. And you do have these other options there.
Mm-hmm.
And quite often these patients will live for quite long periods of time, actually. And so a lot of how you approach it, I think, is going to be about quality of life and not necessarily doing things heavy-handedly too early on. So, yeah, maybe that's a nice little message to take home. So we should probably maybe wrap up, which is just to say single-agent T-VEC, first approved oncolytic viral therapy for the treatment of cancer. So that's a milestone and a landmark. We're going to come on and talk about combination approaches, and I think we'll see more of these over the next few years.
Yep. Sounds good. Thanks for that.